Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Hello, and a very warm welcome to all the surgeons, doctors, and clinical staff joining us today.
Yes, welcome everyone.
You are the absolute engine of the healthcare system, and today's deep dive is designed specifically with you and your daily practice in mind.
Exactly.
But before we jump in, we do have a mandatory disclaimer we need to get out of the way.
Right, the legal stuff.
Yeah. So the information discussed in this deep dive is for reference purposes only. You must always follow local guidelines and protocols in your own clinical practice.
That is a crucial baseline. I mean, every trust, every health board operates under its own specific policies.
Right.
So really look at today's discussion as an exploration of the overarching national frameworks that, inform those local rules on your ward or in your theater.
Exactly. So what is our mission today? We are taking a really comprehensive look at NCEPOD.
The National Confidential Enquiry into Patient Outcome and Death.
That's the one. We're going to unpack what it actually is, how it works behind the scenes, its very real impact on day-to-day medical and surgical practice, and probably most importantly,
how you can use its findings to directly improve patient care on the ground.
Exactly. We have a massive stack of material covering its history, its methodologies, and its clinical applications. So, okay, let's unpack this.
It's a brilliant topic to tackle because NCPOD really is the unsung hero of modern clinical governance.
It really is.
For anyone working in perioperative and emergency care, it acts as this invisible scaffolding that supports so much of what you do every single shift.
Yeah.
But precisely because it's so deeply baked into the system, it is incredibly easy to lose sight of where it came from.
And how profoundly it shapes the delivery of care across the UK.
Right.
It's just hard to imagine the NHS functioning without that scaffolding now. What did the landscape even look like before the 1980s when this first started?
It was very different.
Because we're talking about a time when it was just CEPO, right? CEPOD.
Without the N for national, yeah.
Yeah.
It was heavily siloed. Back in the early 80s, it started as just a series of regional audits.
Just regional.
Yeah, and they focused strictly on anesthesia-related and perioperative mortality.
So very narrow.
Highly focused. There wasn't a unified, overarching mechanism to look at surgical mortalities and ask, could we have done this better systemically?
Right.
But it quickly proved its immense value. By 1988, it transformed into a national program.
And then the first report came out.
Exactly. The very first major national report dropped in 1990, and it set a totally new, unprecedented standard for how the medical profession looked at surgical outcomes.
But the big pivot, though, the moment it became the NCEPO we know today, that happened in 2002.
Yes. The remit was deliberately and significantly widened that year.
Because reviewing perioperative deaths was crucial, but it wasn't the whole picture.
Right. The leadership realized that.
Yeah.
So they expanded the scope beyond just surgery and anesthesia to include medical patients.
Huge shift.
And they also broadened the focus from solely looking at mortality to the much wider concept of patient outcome.
Hence the name change, adding outcome to the acronym.
Exactly.
It's a highly logical progression. Why wait for a mortality to review the quality of care when you can look at broader outcomes and catch systemic issues much earlier in the pathway?
Spot on.
Today, it covers all specialties, all outcomes, though emergency and perioperative care definitely remain its core beating heart.
For sure.
And structurally, it's an independent registered charity based in London. It operates for the NHS across England, Wales, Scotland, Northern Ireland, and the Channel Islands.
And that independent charity status gives it a vital layer of objectivity.
Because they're commissioned through the National Clinical Outcome Review programs, right?
Right. But operating independently allows them to produce incredibly detailed, themed reports on everything from surgical emergencies to mental health without political interference.
So how does the actual machinery of NCPOD work then?
It's quite a process.
Getting from a broad topic like acute bowel obstruction to a highly specific national recommendation, that requires a massive logistical lift.
What's fascinating here is the methodology. It's not just a quantitative exercise of crunching vast data sets or mortality statistics.
Right. It's not just a spreadsheet.
No, it's highly qualitative. It relies heavily on in-depth peer review.
Okay.
First, a study advisory group defines the specific topic, the inclusion criteria, and the required data items.
And then hospitals across the UK submit data on eligible cases.
Yes, within a defined sampling period.
And from that massive pool of data, a specific sample of cases is selected for a deep dive review.
Right.
And these reviews aren't done by algorithms or administrative staff. They're done by multidisciplinary panels of actual practicing clinicians.
Clinicians who are entirely independent of the teams that actually treated the patients in question.
That's key.
Very. These reviewers dig into the granular details of the case notes and specialized questionnaires. They are looking at the entire patient journey.
Like organizational inputs.
Yeah, and the clinical decision-making process, timeliness of interventions, whether senior clinicians were appropriately involved.
The quality of documentation.
All of it. They grade the overall care, highlighting excellent practice, but crucially, they identify what are called remediable factors.
Remediable factors. That is such a crucial term.
It really is.
It shifts the focus away from who made an error to what systemic or clinical elements could reasonably have been done better.
Exactly.
And this ties directly into a massively important point about the entire philosophy of the organization. It relies entirely on a blame-free culture.
Completely blame-free?
Patient, clinician, and organizational data are strictly anonymized in the outputs. No individual doctor or hospital is ever named and shamed.
Which is vital, because if people felt they were going to be publicly penalized or dragged through the mud, the data submitted would inevitably become defensive.
Of course it would.
By making it confidential and blame-free, it encourages genuine transparency.
And participation isn't just a nice-to-have, is it?
No, it's a professional duty. For UK doctors, engaging with national clinical audits and confidential inquiries like this is an explicit expectation of the General Medical Council.
Yeah, commissioners require all NHS trusts and health boards to participate in these studies and report their engagement. It's built into the DNA of the modern hospital.
Absolutely.
They're moving from the overarching philosophy to the sharp end of daily practice. Here's where it gets really interesting, especially for our listeners who are actively managing theater lists and battling with bed managers.
The real day-to-day stuff.
Exactly. NCEPOD provides one of the most practically relevant tools in surgery, the NCEPOD classification of intervention.
Also known universally on the wards as the urgency scale.
The urgency scale.
This was a monumental game changer because it standardized how we categorize the urgency of operative and interventional procedures into 4 distinct categories.
Because before this existed, terms like emergency or urgent could mean very different things.
Completely different things depending on which surgeon or anesthetist you asked.
Right. And we don't need to define what these words mean in plain English, you all know that. But let's look at how NCEPOD rigidly defines the governance around these 4 categories.
Yeah.
Starting with Category 1.
Category 1, immediate.
Immediate.
When you are staring down a ruptured abdominal aortic aneurysm or a crashing trauma patient, you are looking at a Category 1.
Life, limb, or organ-saving intervention.
Yes. The defining characteristic here is that resuscitation is often happening simultaneously with the surgical intervention.
You don't have time to wait for the patient to be perfectly optimized.
No time at all. The target time here is measured in minutes from the decision to operate.
You take the next available theater, even if it means you have to break into a current, ongoing elective list.
Yeah.
It is the absolute highest priority, no questions asked.
Right.
But the real friction on a busy shift often happens with Category 2, doesn't it? The urgent cases.
That is where the clinical judgment really gets tested. The definition here is an acute onset or deterioration of a condition that threatens life, limb, or organ survival. So think of an acute abdomen requiring source control or many types of fractures.
But what's the key distinction with urgent versus immediate?
It's the time frame and the patient's physiological state. The target time is within hours of the decision to operate, but usually this intervention happens after resuscitation is completed.
You want the patient optimized first.
Exactly.
You get the fluids in, you start the antibiotics, you stabilize the hemodynamics, and then you take them to theater.
Right. And the theater provision for this should be a daytime emergency list or a dedicated out-of-hours emergency theater.
Okay, so moving down the urgency scale, we get to Category 3, expedited.
This is for a stable patient who needs early intervention, but there is no immediate threat to their life, limb, or organ.
So they're stable.
Because they are hemodynamically stable, the target time extends to within days of the decision to operate.
And for theater provision, this should happen on an elective list that has capacity or on a daytime emergency list. But notably, the NCEPOD guidelines Specifically draw a hard line here.
A very hard line.
An expedited case should never be done at night.
Never. Doing non-life-threatening procedures out of hours introduces totally unnecessary risk due to fatigue, reduced staffing levels, and limited access to support services.
Makes total sense.
NCEPOD strongly advises against it, which gives clinicians the backing they need to say, no, this can wait until tomorrow morning.
It's great to have that national standard to lean on. Finally, we have Category 4, elective.
The bread and butter.
Exactly. As a surgeon or anesthetist, you all know what a planned intervention is. But what NCPO changed wasn't the definition of elective surgery, it was the strict governance around it.
The operational protocol is what matters here. NCEPOD mandates that the consultant who is actually going to perform the procedure is the one who must assign this urgency category.
And they have to do it at the exact time the decision to operate is made.
Right. It prevents administrative drift.
You can't just leave it blank on the booking form or let a junior colleague guess the urgency later on.
No, it must be explicitly recorded in both the theater booking system and the patient's case notes.
Because it's the metric used to prioritize cases.
Exactly. To prioritize cases on emergency lists, to audit any delays in getting to theater, and to monitor the volume and appropriateness of out-of-hours operating.
So the impact is huge.
If we connect this to the bigger picture, you start to see how these classifications actually change the physical layout and staffing of a hospital.
Service organization?
Yes. NCEPOD reports have repeatedly championed massive changes in service organization. The most prominent example is the creation of dedicated emergency surgery lists.
Often colloquially called CEPOD lists.
Exactly.
Imagine the old days of trying to squeeze a hot gallbladder or an obstructed hernia between two routine hip replacements on a mixed list. It was chaotic.
Dangerous, really.
NCEPOD made it clear. Any hospital admitting emergencies must have a staffed emergency surgery list and a fully equipped theater suite.
And crucially, it needs consultants who are rostered specifically for this emergency work.
Entirely free from any elective commitments.
Right. You cannot be managing a complex acute abdomen if you are simultaneously supposed to be running a busy outpatient clinic.
That dedicated focus saves lives.
Absolutely.
And NCPOD's impact goes far beyond just theater management. Take upper gastrointestinal bleeding as a prime example.
Oh, that's a huge one.
The data on upper GI bleeds was eye-opening. A major report highlighted severe deficiencies in both the diagnosis and treatment of these patients.
You had patients actively bleeding on medical wards who couldn't get access to an endoscopy out of hours.
The data clearly showed that patients were suffering simply because the system wasn't set up to deliver the right care at the right time.
And the resulting recommendation from that report mandated 24-hour access to appropriate specialists and endoscopy services for these patients.
It directly changed the national standard of care,
forcing hospitals to rethink their on-call rotas and interventional radiology access.
Another massive shift came from their inquiry into non-invasive ventilation, or NIV.
Yeah, NIV.
It's incredibly common on acute medical units, but the report uncovered some deeply concerning trends.
The inquiry identified a distressingly high mortality rate associated with NIV use.
But by looking closely at the remediable factors, the independent reviewers found the root causes.
It wasn't that the machines were faulty.
Right.
It was systemic clinical issues. There was poor case selection, inadequate physiological monitoring on general wards, and major failures in escalating care to ICU when the NIV was clearly failing.
And that report drove stringent new recommendations on nursing ratios, staffing levels, and strict clinical protocols for NIV across the entire country.
It's a perfect example of NCEPOD in action.
And they don't just stick to the traditional surgical or acute medical pathways. They have revolutionized areas like the management of mental health within general hospitals.
Which is so important. The silos between physical and mental health care have historically been very rigid. NCEPOD did a deep dive into the physical health care provided to patients in mental health inpatient units, and conversely, how general hospitals manage patients with acute mental health crises.
And they highlighted the danger of diagnostic overshadowing.
Right, where a patient's physical symptoms are wrongly attributed to their psychiatric condition.
Recently, they've been doing vital work looking at health inequalities as well,
drawing attention to stark disparities in access and outcomes based on age, disability, deprivation, and inclusion health status.
They are actively framing a hospital admission not just as an isolated treatment for an acute episode.
but as a critical, sometimes rare opportunity to address a marginalized patient's broader unmet health needs.
It is a completely holistic, system-wide lens.
It really is.
So what does this all mean for the clinician listening to us right now? We know NCEPOD changes national policy, but how does it impact your Tuesday morning shift?
The daily grind.
Let's talk about concrete day-to-day responsibilities. First up, documentation as advocacy.
Actively classifying and documenting the NCEPOD category at the point of decision is paramount.
It's your primary tool for advocacy when dealing with a busy theater coordinator.
Exactly. If you have a Category 1 immediate case, having that classification clearly documented is your objective justification to break into an ongoing list.
You don't have to argue, you just point to the standard.
Right. And conversely, it empowers you to challenge inappropriate administrative delays when a Category 2 urgent case is inexplicably pushed back.
It gives you an objective, nationally recognized standard to point to when you're fighting for your patient's access to theater.
Another massive day-to-day responsibility is ensuring appropriate senior decision-making.
Yes. NCEPOD takes an incredibly firm stance on consultant involvement, don't they?
Very firm. Time and time again, across multiple different specialty reports, the data shows that decisions to operate on very sick, complex, or elderly patients absolutely must involve consultants.
The era of junior surgical registrars flying solo at 3 a.m. to make critical operative decisions on unstable patients is over.
Long over. And NCPOD's findings have been a primary driver of that essential cultural shift.
Which brings us to perhaps the most delicate clinical balance that these reports constantly highlight, the resuscitation balance.
Oh, this is a big one.
There is a constant tension between the urgency to cut now and the absolute necessity of preoperative resuscitation and optimization.
It is the classic surgical dilemma. The patient needs the operation to fix the anatomical problem, but they are too physiologically unstable to survive the physiological hit of the anesthetic.
Yeah.
What NCPOD has found repeatedly is that inadequate preoperative assessment and optimization is a major recurring remediable factor.
Rushing a poorly resuscitated patient to theater, unless it is a true Category 1 simultaneous resuscitation scenario, almost always leads to worse outcomes.
Almost always.
It's about taking that crucial time to stabilize hemodynamics, correct electrolytes, and optimize oxygenation, even when the clock feels like it's ticking loudly.
So we have these national reports, these standardized urgency scales, these clear mandates for senior review. How do we actually implement this locally?
Yeah, how do we use it?
The most effective approach is to view NCEPO as a proactive educational and governance resource.
Not just a punitive external audit that you only care about when your trust is being sampled.
Exactly. You can proactively use the summary recommendations from relevant reports, like the ones on acute bowel obstruction or the perioperative care of the elderly, to inform your own local practices.
Taking the national data and building it into your local ward culture is how real change happens.
You can use their findings to build better pre-op checklists, to structure your clinical handovers, and to set clear evidence-based thresholds for when to escalate a deteriorating patient to a consultant.
And a highly pragmatic way to do this is through your departmental morbidity and mortality, or M&M meetings.
M&M meetings are the perfect vehicle for this kind of cultural integration.
Because instead of just reviewing a complex case in isolation and asking who messed up,
you can align your local case reviews with established NCEPOD standards.
So when you're reviewing a complicated case, you explicitly ask the room, was there a delay to theater based on the NCEPOD urgency scale? Was there appropriate documented senior review prior to intervention?
Were the ceilings of care clearly discussed and documented?
Right. Bringing those specific themes into the room makes the M&M much more structured.
It shifts the entire focus of the room from individual blame to systemic improvement based on national best practices.
It makes the meeting genuinely improvement-focused.
Which is exactly how NCEP is intended to work. It is a national learning system that relies on clinicians actively engaging with the findings to incrementally, consistently improve patient outcomes across the board.
So to quickly summarize the ground we've covered today, we traced NCEPO's roots from a siloed regional anesthesia audit in the 80s to the massive multi-specialty national learning system it is today.
We explored how it relies on transparent, qualitative peer review by independent clinicians.
Right, to identify remediable factors without assigning blame. We discussed the essential 4-tier NCEP classification of intervention.
Immediate, urgent, expedited, and elective.
And how crucial it is to use these categories to advocate for your patients. And finally, we discuss how active clinical engagement with these reports, especially around senior decision-making, the resuscitation balance, and structured M&M meetings, directly improves the care you deliver every single day.
This raises an important question. If NCPO has definitively proven over the last 3 decades that anonymized, blame-free peer review leads to massive, life-saving systemic improvements at a national level, how can we foster that exact same level of psychological safety and transparent learning in our own local team microcultures on a daily basis?
That's a great point.
How do we make our own wards and our own departmental meetings as genuinely blame-free and improvement-focused as a national confidential inquiry?
That is a fantastic, highly practical point to end on, and something for everyone listening to mull over before their next shift or their next departmental meeting. Thank you so much for joining us on this deep dive into the architecture of clinical governance.
Thanks for listening.
If you like this content, please do not forget to share it with at least one of your colleagues or friends to help spread the word. It really helps us out and keeps the conversation going on the wards.
It makes a huge difference.
Also, make sure to check out our YouTube channel and our other social media pages for more clinical content.
Wow.
And finally, do check out our previous season and deep dives, which feature some very relevant topics to keep you well informed on the latest in clinical practice. Until next time, keep up the amazing work you do, and we will see you on the next deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.